Hello and welcome back to Quantal U episode 15. I'm Dr. Ep15 and today we'll be discussing direct primary care, or what we call DPC for short. This up-and-coming new healthcare model has gained traction and most recently has been growing leaps and bounds due to the very poorly managed COVID pandemic. This caused worsening of an already difficult work environment for many, increasing workloads as well as increasing overall stress. Now more than ever before, doctors and healthcare workers are seeking employment outside of the normal healthcare construct. The term direct primary care simply and easily means medical care without the use of insurance. It cuts out the middleman. So how does it work? Well, each business is a little different. However, the general idea is that the person or family who are signing up pays a monthly membership fee. The average monthly fee is approximately $100 per person. This fee typically pays for all annual and regularly scheduled visits. It also covers sick visits and last-minute needs. Additionally, it covers a myriad of procedures such as mole removals, suturing, casting, and most in-house procedures at no extra cost. Many times the doctors have contracts with companies for decreased costs of lab testing, imaging, and many other types of medical services. And most importantly, it gives the ability to grant and promise the time our patients and we so desperately need. Since DPC physicians take care of an average panel size of approximately 400 patients compared with caring for 1,800 to 5,000 patients in traditional healthcare, they have the ability to spend the time when their patients need it most. And by offering same or next day appointments in addition to direct texting to their doctor's phone, they can get questions answered easily and quickly. This decreases the stress, worry, as well as unnecessary visits to the ER, saving you both time and money. So even with all of these incredible benefits, I still highly encourage everyone to invest in a health share plan, which would cover any major medical problems you'd have to deal with. I was fortunate to have been able to use my health share plan for knee surgery that was needed last year. Without it, I'm not sure what I would have done. So make sure you're covered. Our next guest is one of the leading docs in this movement and has been a DPC physician since 2014. She has a lot of great information for both patients and physicians looking for a different way to practice. So take a look.
So I'm Dr. Julie Gunther. I'm a board-certified family physician. I finished residency in 2009, opened my own direct primary care practice in 2013-2014 in Boise, Idaho, called Spark MD, and we provide comprehensive family medical care for a membership fee. Direct primary care, so there's some pretty robust definitions, but in its simplest form, I am and my team are people's healthcare clinic, and those people are patients who are our customers, which many physicians don't like to call patients customers, but pay a monthly fee. So it's an extremely simplified healthcare delivery system. What I like to say is direct primary care is a different business model for primary care. It is not alternative healthcare. So there's been a rise of people getting the majority of their medical care from chiropractors or people with different licensure, not MD or not DO. And direct primary care is not a fringe model of medical care in terms of the science, but it is an innovative or potentially even fringe model of medical care when it comes to how we bill. So most direct primary care clinics do not bill insurance, don't participate with insurance, and frankly can't do what they do if they were to participate with insurance. So it's a simplified model of medical care where I'm your doctor and you pay me. There is a gaggle, more than a gaggle, I think a gaggle's, I don't know how many a gaggle is, 8, whatever. There's a group of people who are certainly innovators or pioneers before me, and some of them served as my mentors, and I certainly learned and benefited from their discovery. So Atlas MD out of Wichita, Kansas, I think they just celebrated 10 years. They may be at 11. Dr. Ryan Newhoffel, also out of Kansas. Brian Forrest out of Apex, North Carolina, was in a medical economics article that my husband sent to me in 2010 saying, hey, look at this model. Garrison and Erica Bliss are cousins or founders of Q-Liance, which is a cash-based model out of Seattle that is no longer in operation, but really did some innovative things in this space. I think Clint Flanagan out of Nextera is ahead of me timeline-wise, or we're about the same. So I certainly can't take credit for this being my idea, nor for being one of the first people that tiptoed into this space. There are names that are forgotten in this movement that went even before a number of us who are still open, who honestly, as the folklore goes, had to fight pretty tremendous legal battles to say, hey, I'm a doctor, I'm not insurance. So as far as I'm aware, I'm one of the early female providers in this space, and I'm also one of the most vocal female providers in this space. So I've spoken and tried really hard to share what I've learned with others. But when I came into direct primary care, were it not for a few of the people who'd already kind of figured out this footprint, I would have had a much tougher road. And so there's been a culture of collective mentorship that has continued, that I certainly benefited from and hope to continue to contribute to.
Yeah.
Well, and I like to play with words, and I truthfully didn't take Latin, so I don't know what the word colleague means. But what it means to me, I had all kinds of visions for what it would mean to be a doctor. And when I worked as an employed physician, in hindsight, and even then, it was one of the most profoundly isolating experiences. Personally, professionally, from no one even having time to pause and say, gosh, I saw your favorite patient passed. You okay? Need a break? Your kid broke their arm. I'll take your afternoon. Like, have you ever heard of a physician being like, let me see your patients today? Like, when I first started out in residency, which makes me sound really old-timey, that was a standard that I saw. And I worked at an on-site clinic in a PRN job, and came in one day and had no one on my schedule, and the other 2 full-time providers that worked there were double, triple booked. And my attitude is nothing's free, and I don't mean to say like, oh, I'm some sort of hero, but I came in and said, I'll go see the sore throat, the sore toe. Like, I can chip off the easy peasies. And I was actually told by an administrator, you're not allowed to do that because we can't flip the provider in the computer. Like, you're not allowed. And these things happen that just not only don't make any sense, but they profoundly erode the moral culture of medicine. And so colleague, in my opinion, means you feel like you're not in the trenches alone, or you feel like, at least if you are in the trenches alone, the arrows are all pointed out. Like you at least know, you're like, I got to do this myself, but at least the people who are also doing this themselves aren't shooting at me. And as a metaphor, I never felt as optimistic about other doctors as I did until I became a direct care physician. Now, that doesn't mean I get along with all my colleagues. That doesn't mean we don't have some knockdown, drag out debates, especially on social media. That doesn't mean we're not very diverse in our political opinion, but I think there is an intrinsic, very high regard for what each of us are trying to accomplish, which is just to authentically be a doctor. And so I value that. So when we see the continued rise of this movement, with people being able to add employers in a bigger number, so there really are 2 employer models here. One is the micro employer, where they say, hey, this is cool. If our employees want to go there, we'll pay for the membership, we have about 11 or 12 employers with that. That's a very different business impact than, all right, we have 300 people. We're going to try you out for a year and pay for all 300. And work with a TPA or an insurance company on the higher order benefit, right? So you get a fixed influx without a guaranteed utilization, so to speak, right? And that honors the benefit of, like, if all you're doing is helicopter doctoring, so to speak, so that person doesn't pew to the urgent care once, you're saving that employer money. But when we talk about employers in DPC, those are 2 different models. The one of the 300, 500, 2,400, whatever, that allows rapid addition of a physician. It's really hard to get to a physician level of income or any sort of supporting income with the micro practice growth, the onesie twosies. because you have this micro incremental growth and it's hard to get to a point. So most people are dropping their own salary to add someone. And that's where an NP or PA can come into play, because many NPs or PAs are sometimes looking for less than full-time work, and their pay grade is different. So I like to be really straight with this, because there are people who jump into DPC who feel like they are misled. I have come to believe, and you'll have to interview me in like 20 years and see if I still think this. Taking care of people is really hard. And I think we need to say that, and we need to acknowledge that. And taking care of people when you have committed yourself to their whole story is harder. So I think all physicians have an incredible challenge, but a number of physicians have a tap out button. Their shift ends, the surgery's over, right? So they care for people in aliquots. And it's not to say that's not difficult, but it's a different challenge, and it may be harder even. It's very hard to build rapport instantly, to make good clinical decisions and have a plan of care when you just met someone, right? I get to know people, and so I can know why they kind of went sideways at the orthopedist office that day. I know that my patient Bob falls apart every February because his first wife died of breast cancer in February. We had a team meeting yesterday where I said, okay, we're going to start hearing from so-and-so and so-and-so and so-and-so, and I just want to remind the team why. Because I've been some of these people's provider for 10 years. I now have a team helping care for people. But I said, this is always when, Jane has an uptick. So that's an incredible gift to be welcomed into people's lives that way. It's an incredible privilege to be a part of something authentic, which is what primary care gets to do if we create an authentic space for exchange. But it doesn't mean it's not a huge pain in the ass sometimes, and it doesn't mean it's easy. I think some physicians are coming to direct primary care with the hope of self-discovery and the hope of finding a safe place to be the physician they wanted to be. And I think you very much can do that. But the work itself has its own moral and emotional draw. And I think DPC as a business construct makes that draw more sustainable for physicians. It lets you share a physical and emotional space with a person long enough that it has integrity, but it doesn't mean that being a physician still potentially doesn't have a tap out date for some people, or that the way you do it doesn't change. My number one recommendation to people is you have to figure out if autonomy is a reward for you. And that's really hard to know if all you've ever wanted to be is a doctor, because you've got the grades you needed to get, you filled out the applications you needed to get, you went to the college, you've had deliverables put in front of you and you've executed on them because you had a vision for something you wanted. And then you get there and now you say, actually, does innovation, entrepreneurship and autonomy excite you and pay you dividends beyond money? And if that does, then DPC will pay even more dividends, because you get to do all that and take care of people. I'm not a qualitatively different physician. Like, people say, oh, do you think you provide better care? I provided similar care when I was employed, but to a profound personal detriment, super far beyond what happens now. Now, if I don't want to see anyone tomorrow, so the patient I saw before our interview today needed a cast removal on Monday. I didn't have the supplies I need. I just called her, said, can you come in Wednesday? Yeah, great, thanks, Dr. G. Right, so she gives me grace, I give her grace. I have kids, all my patients know that. If there was something that needed to happen at noon tomorrow, and I know right now I have a patient scheduled, I could call that patient, my team could call that patient and say, hey, Dr. G, totally flaked. She has a family commitment. And I could never do that when I was employed. My intellectual ability was not honored with the idea that I'm a responsible adult and I'm gonna get the work done, right? So to just be able to be a human, direct care really lets you do that. It also, patients see so much more. It's weird. Right after I opened, I started getting gift baskets and plants and thank you notes. And I was like, I did not do anything different for this well woman check than I did when I was employed. But the patient's perception, or not perception, their awareness of how much you do changes in direct care. And I think because from our end, like I remember in the beginning it was weird. I had never seen the waiting room. That's not entirely true. I used to room my own patients and then I'd get in trouble for it. Like if the nurse was behind or I got ahead, I was always like, show up, work, like just churn, get everybody out of here and then do notes. The patients are, most of my patients are substantially more appreciative, which is interesting and sad actually, because I have, and I say this all the time, I have great colleagues who still work in the system. And patients will say, well, you know, Dr. So-and-so's no good. And I'm like, it's actually generally not Dr. So-and-so. It's the system structure creates so many barriers that by the time the patient gets to the therapeutic provider, they've had to work so hard to get in the door and they've told their story so many times and spelled their name so many times and listed their birthday so many times. And then you have 8 minutes. The whole thing, it's sort of like a wedding, and by the time everyone got to the altar, like it was such a shit show before it that's not even worth it. You know what I mean? So no matter what work is being done by physicians, what good work is being done there, they have to remedy the runway, the experience the patient went through before they got there. And then I think patients are just wiped out by the end. And so, but it was just very weird to me that all of a sudden there was a perception that I was providing such better care or so much more care when it was what I did before. No, I think you're correct. And from a personal standpoint, and this is me sort of taking advantage or maybe not. So I had breast cancer in 2016, which was 2 years into startup. And I had one patient or two say, oh, you know, now you know how we feel. The vast majority of my patients are highly respectful and understand, like, you just kind of renegated it, you went out because you wanted to do things your way. So there's never been suggestion from most people like, oh, you needed to feel how we feel. But I have to be, just being completely transparent, you know, a hospital for which I was on the medical staff made many mistakes related to my healthcare. And that's with me, a very involved physician, paying very close attention, with a very capable, very intelligent husband who insisted on being with me all the time. And what's profoundly terrifying to me is, I mean, we've both said, like, if this is happening to us, and I don't have good luck, so maybe that's just it, I'm like a black cloud, but it's really gone too far. Because for all the talk of quality, and I had one day that I spelled my first and last name and my birth date 7 times. In the system that has the very good EMR that says why I'm there, but because of HIPAA, only certain people can see it. So what system care for me did was many really amazing things. Amazing surgeon, amazing oncologist, well, my second one. I mean, I'm grateful for what modern technology and my very capable physicians did, because that's why I'm still alive. But on the other hand, once you've spelled your name and birth date 7 times and then told the place where you had surgery that you're right on Protect 7 times, you start to feel scared. And so then when a patient gets a little testy maybe, and then people, we know what, there's this sort of maternal paternalism, we know what we're doing. And I want to say, I don't think you do, because I've been here an hour and I've had to answer the same question 7 times. And you're telling me it's for my safety, but it's not for my safety. What if I only met one person? And what if that's the person I met last week? And what if they knew my name was Julie? Because you know what is absolutely the #1 way to maintain patient safety? It's when the human brain knows the other human. No computer, no Face ID, no birthday, no MRN. It's actually, you walk through the door and I know you because I've met you. And so I would contend, and I don't know how we scale it, but it is scalable, that the human, not the robot, not the light that keeps going out, not the phone that battery dies, the human is the most protective part of our healthcare system. It's also potentially the most error prone. But the irony is the human brain is the thing that knows, no, this is John, and it was his left arm that was hurt, right? So I think we have to give the humans in the healthcare system, both patients and providers, enough time to do their work with high quality. And that is more protective than any armband with the wrong allergy on it, or that goes up and occludes an IV and necroses a person's hand. All of these things are real things. Like these checks and balances are fake. And they cannot replace what it means to just know somebody.
Yes.
So the way you give high quality care is you give the patient and the provider enough time to finish their conversation. And the beauty of that is no patient is ever able to tell you exactly how much time they're going to need. So you have to build in an error margin to allow a visit to have a natural beginning and a natural end. So that's what direct care does. It lets the natural rhythm of patient care occur most of the time so that the provider and the team can treat the patient as an individual. We have a patient who's just lovely, an older gentleman. He's in his 70s, and he's been my patient for maybe 4 or 5 years. He's got really big knuckly hands and just really beat up skin. He's kind of a tough old rancher dude. And he got a spontaneous infection in his limb last year, just very, very, very weird. And I remember saying I said, have you ever had an autoimmune disease? And he's an intelligent man. You went through all these things, all this workup. No. So he had COVID, made it through it, and then like 6 weeks later, he's just profound joint pain everywhere. So this is kind of a workup underway. So he comes in, we start a workup, and then one of my nurses is doing a blood draw, just talking to him, and he's like, I was thinking about it. About 30 years ago, I was on this drug methotrexate. And I had a doctor that was a joint pain doctor. And so, the whole team's like, we've tried, and it turns out he has psoriatic arthritis. So we have tried for like 5 years, and it's no amount of questioning, it's no ill will, we have hour-long visits, we've scoured everything, and it's just, these things don't come out. And this is a simple example, right? You think about trauma, abuse, neglect, some of the deeper things that really, sexuality, all these things that people hold at a different level of their iceberg, so to speak, that when you work with people, it just, there's time until they have the bing, I guess, that Dr. Roman referred to too. And on one hand, I love that about primary care. And on the other hand, it's an incredible exercise in patience that makes me crazy, because I had a patient 8 years in, just side note to a med student about a very traumatic event that sort of unraveled the whole story. And I don't think people hide those things from us. I don't like that, we need to train patients. Patients know how to communicate. If you live in society and you communicate, you shouldn't have to change how you communicate to speak to your doctor. You know what I mean? So we need to integrate our communication style with. They're advancing coding and charting, but they're not, and that's just the irony. And I'm not trying to be critical of that, but just the insanity of it is there's so much work being done. Yeah. And I don't know what physicians are supposed to do. Because what's happened thus far is we have been picked off one at a time, or allowed to be marginalized one at a time, and everyone kind of comes to their truth slowly, and you look around and you think this complication occurred because of this process, or physicians speak up, but until we speak up en masse, it's not going to change. And I don't know how we speak up en masse, because we're not a society, our physician society as a whole, that does that very well. I just think that anything I need to talk to a doctor about, or a dentist or an orthodontist, if I'm going to reserve time and go talk to you about my face or my teeth or my health or my eyes, it's going to take longer than it takes me to get my Starbucks in the morning, right? And I've said that before. So what was so empowering to me was to start to try to remove myself from these complexities and think about them metaphorically, or think about them just logically, and be like, I am broken, I am suffering because I'm trying to make something happen in a construct that isn't designed to make that happen, right? So I'm trying to make a cake in the bathroom. It's not that I'm bad at making a cake, I'm just in the wrong place, So that was extremely empowering, but also extremely upsetting to me, to realize it wasn't me, it wasn't the system, it wasn't my employer, because I thought, it's just this place. To be like, no, the whole business construct of healthcare isn't actually designed to take care of humans.
It's not.
Which I guess is a radical thing to say. But when patient after patient says Why did it happen? I'm just like, I don't know how to tell you, but the ER is actually not designed to provide like
Primary care. No.
care for you.
Right.
It's designed to decide if you're dying,
Right.
you're in trauma, or you meet medical criteria for admission. Now, with that said, though, the rise of overutilization of the ER is a massive healthcare problem, and primary care needs to divert and have a different model to help reduce that. Right? Your doctor's not available after 5 p.m. What do you do if you cut your hand or whatever? So, DPC solves some of that, but. And I would love to give our healthcare system the grace to understand the grace of like COVID, but this is before COVID. And we have a patient right now, end-stage dementia, metastatic prostate cancer, but stable after Lupron, came in with a sore throat, gave him antibiotics did a car visit. And anyway, long story short, 3 weeks later, still a sore throat, voice changes. Sent him to the ER. He has a new tumor from behind his tongue all the way down, crossing midline down to here, compressing his airway. They sent him home with an oral steroid, prednisolone, told him to be careful when he swallowed. Didn't dose him steroids in the ER. Now, he was probably there unaccompanied because of COVID. So that's the other thing I don't even know. People who can't advocate for themselves, which frankly nobody can when they're sick. We called him that night because I saw the imaging, and we had liquid prednisolone here, and his wife came and picked it up here because none of the pharmacies had it in, so she was just going to go get it the next day. This is like a month ago, he's now had a biopsy. He did 5 days of induction chemo in the hospital by himself with end-stage dementia. And I mean, it's just like, what are we doing? I get to do what I want to do when I want to do it. And I'm a workaholic. I over-deliver for my own benefit. And those are intrinsic problems to me. And those are the things, when you have an interview, you're like, well, I work too hard. I'm like, and people are like, oh, she's great. But these are not necessarily healthy things. And I have a very strong personal belief that the process of getting where I am is why I got cancer. I do think cortisol and sleep deprivation and stress, and it's not just me thinking. So I believe the price I have paid thus far to do what I do has been a big one. But the other thing is, many people still do hold physicians in high esteem. I get to be the part of very intimate parts of people's lives, and that feels normal to me, but I think that translates to all other components of our lives. I have seen death many times over. I have seen birth many times over. I have patients share with me over and over again, if only I had whatever. So I feel like I sit in a privileged place to potentially live a better life because I get lessons shared with me that maybe normal people would hear once from grandma or grandpa. So if you take those moments and use them as, little pieces of gold for yourself, I think they can provide some guidance and wisdom that other people don't have access to because they don't consistently work with people on this level of intimacy. Again, that requires time. So, healthcare and being a doctor has given me a lot. It has taken a lot. And on balance, I don't know which one is heavier. Financially, there's a lot of promise of financial wins in DPC. I would be financially much better off had I stayed in the system. Much, much better off in terms of just raw numbers in my bank account. However, I love spending money. And the beauty of owning your own business is when you're employed and your husband or partner's employed and you're both W-2s, you just can't get anywhere between educational debt, childcare, and nothing's a write-off, right? So owning your own business, I can think creatively, do projects, do things that are business expenses, but also are vehicles for my creativity and my ever-busy mind, and that brings me joy also. Probably my biggest wins in direct primary care are autonomy and flexibility. I don't I can't even fathom what my life would have looked like if I would have had breast cancer while I was an employed physician with RVUs. And there's threads online sometimes of physicians that work in the system where I work, or new people move into town and say, hey, if you work here, do you get vacation? And, oh yeah, and I said, no, I didn't when I was there. What you got was the opportunity to make up your RVUs later, right? Same thing when you had to move a patient. So I like to think that there might have been some grace, but I'm quite confident I would have left medicine, and I probably would have not had the self-discovery that I've had through entrepreneurship, and so I probably would have been much more of a broken person, not just because of cancer, but because I would have fallen into the bucket of, I'm an outcast, I don't fit in, why can't I just follow the rules? Why can't I get my notes done faster? Why can't I be like those other doctors? What's wrong with me? So DPC has also given me this window into entrepreneurship and small business. And I realized I have a lot of varied talents, and I like a lot of things, and I can interact with a lot of people, and that brings me joy. I like making my own brochures. Another side effect of this business, I started this business to save myself to be able to be a doctor, because I figured I've got all this debt and this is what I know how to do, so I better make it work. But every single person that works for me, actually, other than Erin, who's our PA, because she came straight out of PA school here, and she's wise beyond her years. She had zero interest in being employed in a different model. She actually reached out to me in school in the Midwest and said, hey, can I come to a rotation? And was impressive, on email. I said, okay. And she impressed me so much on her 6-week rotation. At the end, we went out to lunch. She said, I want to work for you. I said, I don't have a job. She said, I don't care. I want to work for you. I'll work for you for free. So that's not right. And she had the flexibility to start later than, so we made it work. But other than her, every single woman, it's woman, but if it was a man too, every single person here that works for me has been, I would say, fairly catastrophically abused by healthcare. Many people as a patient and as a nurse, My main nurse worked for our former employer for 26 years and is not doesn't like risk, is very organized, very orderly. And I'm like her worst nightmare in some ways because, she has to follow me around and catch the things that fly out of my tornado. But we had 4 lunches over the course of a year, and our final lunch, I said, you need to decide. Here's what I want to create. I want to create it with you. And I'm going to ask you one thing, because she started healthcare young. I said, can you do this 20 more years? And that was it. She's like, oh my God, I do have 20 more years and I can't do it this way. So, left her pension, left her retirement plan, left the system that she'd worked for forever. What I never thought of was, actually what I want to build is a place where people can work, where they're treated like adults with respect. And that's been really fun and my dad was a small business owner for a lot of his life, and he used to talk about his employees in this way too, but there's other things happening here that aren't always happening in our society, which is treating people with integrity and trust and growing them, or allowing them to grow in a place where they're excited to be. So this is kind of bragging. It's not perfect. We have some hard conversations here. There are things that frustrate me. Every business group I've been in, if I bring up an employee challenge, the first thing most of the other business people say is, we'll fire him. But then I get, oh my God, your shortest person here, shortest duration is our esthetician. She's been here 2.5 years, and that's because I didn't launch with that aesthetics until then. I came from a meeting at the end of summer, and 3 of my staff, esthetician, a nurse, and my PA, were crawling around the grass trying to figure out how to turn the sprinklers on because I hadn't done it yet and the grass was dying, which is ridiculous. I should have a lawn and garden company. And my husband's like, but it's a testament to there's some pretty amazing things if you build a team and you share a mission and then you give people authentic space to do rewarding work. And so I'm very proud of that. If I woke up tomorrow and said, Tanya, I'm not coming in for 6 weeks, which I've never done. That'd be fine. It'd work. And I've created that, and you can create that. And there'd be 1 or 2 people that would be like, I really only want Dr. Julie. But it's been a really, really steep climb. After my breast cancer is when I said, I can't do this myself. I can't. My original model was me and Tanya, or me and my nurse, who's Tanya. Then we'll get to 600 patients and we'll just be done. which is one of the reasons we moved to. Our other space supported that model. It didn't support this model. And then I couldn't do it. I'm great for about 4 or 5 hours, and then I'm exhausted. I have joint pain, some other issues from estrogen inhibitors. And so I set out to say, okay, can we deliver all of these amazing things? Wholesale meds, wholesale labs, same day care, 24/7 ability to call with questions most of the time. We're closed on some holidays. Like, you walk in, we know your name, like friendly experience. You call and you have an issue. I'm sorry, we're gonna handle it. You know, all these things that I feel good businesses should do, but are, as a package, very unique in healthcare. Can we do all that? And then does it still have to be only me? And a lot of people in the direct primary care space say yes, it does have to be only you. And we've had a few patients that have said, yeah, it really does have to be only you. And sometimes there's unique circumstances, but overall the net value of direct primary care is so tremendous that you can build a team and can do it with a team. And then that physician has, I think, autonomy and freedom proportionate to their effort, their education, and their ability. Some of my team have children, and COVID's a mess. So their children were in the break room for substantial periods of time. One of my nurses yesterday, her dog, she rescues animals, it's lovely and wonderful, but her dog was having a really rough time. So, we had a work day yesterday, but she brought her. So she also came in on Saturday and finished raking the leaves, on her own volition. So, I have a team, I have a great team, I have an imperfect team, but there are so many people out there that will move forward with you when you set down your vision. And so there's a lot of rewards. And those for me outweigh the hassles. But I like paying bills. I wish I didn't have to. But I like being the one that looks at the numbers and says, this isn't right. They're always wrong, right? I like the control. I like the money coming into me, and I like being the one where the money goes out if it's going to go out. I like being able to make decisions about purchasing. I like making my own decisions about branding and the website and the brochures. So I enjoy that. And if you hate all of that, you just got to have a higher price point because you got to hire people to do it. And here's the deal. Would you go hang out with your doctor just for fun? Would you?
Possibly.
No, so maybe, but there's this a little bit of like, oh, if I have, if I have give them my text number, or like if I unlock the doors, they're just gonna flood. Patients don't want to hang out with their doctor. They might a little bit because we're funny or we're this local celebrity situation, but like patients have a life beyond our doors. They spend 1, 2, 3 hours a year, 5 hours a year in a normal year in a healthcare transaction. The issue is my whole relationship with them is those 5 hours. So you can get a really conflated sense of your meaning to them. But people would really rather not be at the doctor. So this rationale that like I can take care of 5,000 people or I can take care of 1,000 people, or we acknowledge as a society that a teacher taps out at like 25 and we don't even want our kids in that class. Now I know, oh, it's different. They're there every day. It's actually not. Actually, many physicians have a really hard time with the tempo of DPC. They want to come in, see their schedule, crank, and be done. They're really, I've never bought when people say, oh, physicians don't like to work. I don't know if you've ever heard that. I remember hearing that. I'm like, what are you talking about? If anybody knows how to work, we know how to work. Maybe we're tired, but like when you're cranking at 80 or 100 hours a week, for someone who's lived at 30 or 40 to say you don't know how to work makes me want to just stab my eyeballs. So, the physician that I had with me was fantastic in so many ways. Incredible, diverse skill set, risk tolerant, didn't want to own her own business, but very independent. But she was lauded and very good at doing very complex in-hospital work. And she, by her own admission, got up really early, 5 a.m., come in, get your 18 patient list, and then just head down, burn out by 3, work's done, And so DPC, she'd come in at 8 or 9, there's 1 patient on, or 2 patients on, and it's like, well, I'm gonna go do this instead today, put whoever calls on tomorrow, and that's the kiss of death. You do today's work today as much as you can. So it's a totally different tempo, and what can happen really fast is, you're rounding the corner to 3 o'clock, and then someone calls and needs in today. And You get this frustrated, grumpy, angry, oh. So I've seen it go sideways really fast. It's just a different mindset, and you have to sort of time block and say, here's what I can do when, and here's what we're going to do, and you have to tolerate that. Just assume people won't ever do what you ask them to the first time or the third time. So it's going to be interesting to see. Now, Clint Flanagan has done it very, very, very well, and he has a totally different model with Nextera. So there are people adding physicians and growing this model on behalf of physician employees, but it's going to be interesting to see how that goes, because it rapidly can flip right back to the prior model. And to our physician friends, what I would say, if you want to be employed in a DPC, you need to really do a heart check and a gut check, because what you're really saying potentially is you want to be employed in a small business, and that is different, not even having to do with healthcare. Being an employee in a small business in its startup years is a very different thing. So if you're not jumping up and answering the door, or hey, I got it, let me help, I'll call them back, I'll run those meds to their house on the way home, I'll sweep the parking lot. Like, if all of that sounds disgusting to you, I think you probably, I don't mean disgusting, but if all of that's like, that's not, that's kind of the bag of small business.